Hello, my name is Claude Yancey. I am co-chair of an ACC-sponsored initiative called CREDO, the Coalition to Reduce Disparities and Improve Outcomes. We're excited to bring you a discussion amongst other members of the CREDO leadership to really advise you and to share with you what our perspectives are on how we can narrow the disparity care gap and what we think the strategies are in a going forward circumstance. We cannot allow the population to be impacted by cardiovascular disease without making certain that the entire population understands how gaps in care can be narrowed and understands especially how their own circumstances can be improved in a culturally sensitive, evidence-based, appropriate care delivery system. I'd like to introduce to you the others who will be joining me in this conversation. Let me start to my right with my co-chair for CREDO, Tracy Wong from Duke University Medical Center and the Duke Clinical Research Institute. Happy to have you here.
Thank you, Clyde.
And sitting next to Tracy is Keith Ferdinand, a friend and colleague many, many years from New Orleans, now in Atlanta, who is the scientific officer for the Association of Black Cardiologists and also has an appointment at Emory University. Welcome, Keith.
How you doing, Clyde?
And to my left is my good friend Hector Ventura, also from New Orleans, who really is a champion of causes that impact the Latino community. And he does heart failure and transplantation and directs the fellowship program at Ochsner Medical Center in New Orleans. Thank you for being here.
Thank you, Clyde. Good seeing you.
We really would like to start this discussion off right away. And I think the first question is, what can we do about this? Where do we start? And one place that we've decided to start, Tracy, has been looking at large data sets to understand what is the problem, how deep a problem is it, and are there lessons learned from looking at these large data sets that we otherwise call registries that can better inform the circumstance? Why don't you give us a couple of minutes of a primer on registries and data sets and how we can use those to define the problem?
Absolutely. Well, you know, the American College of Cardiology is renowned for the richness of the data sets that are contained within the National Cardiovascular Data Registry, NCDR. And I think many of the beauties and strengths of a registry are very, very helpful to initiatives such as CREDO. If you ask any physician, do you experience any disparities in care when you're providing care to your patients, it's really hard for that one-on-one question to really raise anything meaningful in terms of what the gaps are and what the future strategies could be.
That's right. It almost generates a defensive response.
It does.
How can you impugn my care?
Exactly. So the registry is able to do this in a way that applies to many, many providers, many, many hospitals, many institutions. And allows, so it's taking a very large population of patients so we can see very clear patterns, especially since it's a pretty comprehensive data set that involves representation from all parts of the country.
But Tracy, I need to challenge you because so many of the listeners will say, but it's not an evidence-based approach. It's not a clinical trial. How do you respond to that?
Well, I think clinical trials are great. They're great for showing one strength of one approach versus the other. It's the only way to truly do a comparison. But remember, for a clinical trial, you're going to need to consent patients. You're going to select particular patients that are suited to be part of your trial. Whereas an observational registry, it's all comers, okay? As long as you've got a diagnosis of an MI or you need an ICD, I mean, you're automatically part of this process. So there's no selection bias.
The target of CREDO reflects those people that are usually underrepresented in
Absolutely, great. Representation is the key issue
So once
here.
you have the data in hand and you say, okay, I see something that's different, how do we transition from seeing these differences to saying it's a disparity?
Well, I see that's where I think we need to be very, very careful because we can't attribute every difference to an inequality in care or what we call a disparity. There are clearly very different factors that are implicated here, both cultural as well as clinical. I mean, there are differences in clinical backgrounds, as I'm sure Keith and Hector is going to talk about a lot here. These are factors that influence clinical decision-making and influence outcomes. And I think, again, one of the beauties and strengths of a registry is that a lot of these clinical variables are accounted for. So we can adjust for those, and then based on that we can also look at differences in treatment patterns, how physicians choose to treat patients, And then we can start to tease out where the true disparities are and what they mean in the context of the differences that you see.
Certainly when we look at the registry and we are benefited by the presence of guidelines and appropriate use criteria, we can say, okay, here is a suite of patients that have a similar indication for an intervention, and then when we count up the intervention and distribute it as a function of the characteristics of that suite of patients, we have an observation that, whoa, it's not equitable. So we've gone from seeing the kind of gross data that says there's a difference to the more precise data that says, despite similar indications, we still see a difference. And now we're getting to a disparity. And so I agree with you. The registry can be a powerful tool in this space.
Absolutely.
But to keep the dialogue going, Keith, what are your thoughts about how we take this information that the data mining generates and bring it to the community? Because after all, we can write the best papers in the world, but if the community doesn't hear the message and work on the message, what's the point? So what happens at that level?
Well, clearly these guidelines and the use of guidelines in inpatient care has made a difference. A recent paper in circulation showed that they were able to blunt disparities between whites, blacks, and Hispanics in inpatient care. But there are two factors that hospitalization doesn't address. That is the patient coming into the hospital and what happens 30, 60 days later. And we've already seen data from registries where you have a narrowing of differences across racial ethnic groups in hospital care, but 60, 90, one-year mortality rates start to separate again, with blacks having the worst coronary heart disease death rates. That is probably driven by a lot of things. One is access to health care. Hospitals do treat people and they treat them well. But if you don't have insurance, or you have limited insurance, or you have limited access to specialty care, you tend then to not get appropriate follow-up in care.
All right, but Keith, you need some pushback here, because everybody listening to this says, okay, but we've got healthcare reform, whatever that means, that's supposed to provide access. So the issues are moot here. Healthcare disparities will go away.
Hasn't happened yet. You know, there are a lot of people who still don't have access to care. Now, in Medicare, which does have some equal access, because everybody 65 or if they're disabled can get Medicare, you do see a narrowing of differences, and that's been shown in analysis.
But the differences are still there.
They're still there.
So why do they persist?
Well, there are lifestyle factors. Certainly, I'm from the African American community in New Orleans. We eat too much salt, too much fat. There's less physical activity. African American females have higher rates of obesity and overweight status, less recreational activity. So there's some things that the community itself must own in terms of lifestyle modification, because even after an intervention, even after hospitalization for heart failure, if you go back to a high sodium, low potassium food intake, if you don't take your medications, you're going to be back to square one.
So, Keith, you've done a good thing here, because you're starting to put this into buckets. So the first bucket, you said, is one of the underpinnings of differences in outcome reflects what we might call patient-level factors, decisions a patient makes that are influenced by a patient's culture. But what about hospital factors, and what about provider factors? Because the discussion we're having here, which is a rich discussion, is even when there's equal access, the data that Tracy will bring forward from looking at registries demonstrates that these disparities still occur. So at the provider level, at the hospital level, what kinds of issues are we talking about, and then what kinds of strategies can we use to overcome that?
Those hospitals that buy into the concept that guidelines make a difference in care seem to do better. There have been data where you have hospitals where a proportion of African Americans seek care. You have less board certification in physicians. They usually don't buy into these registries. They often don't have appropriate levels of care in terms of availability of heart failure specialists, interventionalists for direct angioplasty for people with acute myocardial infarction. So maybe what we also need to work on is not just look at how well those hospitals are doing in terms of tertiary care who are in registries, but how about the hospitals that are outside of registries? Because that's where a lot of the disparate care still goes on.
So we're making some progress here, because we've identified some patient-level factors that have to do with lifestyle choices, the environment, the culture, the community. We've dealt with some hospital factors, and you really crystallize a major concern that there are variations in care as a function of hospitals. And there are also some variations according to language sensitivity, because you have many patients who just simply can't communicate when they're in that environment. But now let's really get to the heart of the matter. What about the provider, our peers, the nurses with whom we work? What are the provider level issues that allow for disparate care, for evidence of disparate care to continue to flourish?
Well, I think electronic health records for the patient, electronic medical records for the system is going to help with that, because most providers don't even recognize that there may be disparate care within their practices. So first we have to identify those disparities. And physicians have to be hard and armored against the fact that they're going to have problems in their patient populations when they're really looked at in an objective manner. Then we have to go back to why we became physicians in the first place. And it wasn't just as a source of revenue. Certainly physicians should be paid for their work, but it was to help people to help themselves. That was an old slogan I had back in New Orleans. One of the things that we have to do is educate our patients to be partners in care. For instance, I have a lady who had an intervention recently. She called me with this medication called Preventative. She could barely spell it or say it. She wanted to know, did she really have to take this medicine?
So that's where the partnership matters.
Somehow in that sedations fog that comes post-angioplasty to the dismissed prescriptions, nobody really explained to her the importance, especially if she had a DES, of taking that medication long term. The same is true in your specialty, heart failure. Within hospitalization, put the patients on an ACE inhibitor, on ARB if they can't take it, utilize the beta blocker, antiplatelet therapy. Look 60, 90, 1 year later,
things are different.
They start to get different. So we have to help our patients. We have to educate our patients. That process probably is going to have to involve video. A lot of people don't read, and that's the truth. It's not a lack of intelligence, but it's the ability to take the written word and transmit it and understand it. And we're also going to have to make sure that things are done in a culturally appropriate manner, translating our materials into Chinese, into Spanish, wherever it's appropriate for the patient.
So I think you've done a really great job of saying we have some community issues that need to be addressed that have to do with lifestyle and culture. We have some system issues that have to be addressed in terms of communication and quality. And then we have some provider issues that need to be addressed. Just bridging the gap, being able to reach out and embrace the patient. And some would say that in a way that doesn't impugn anyone or hurt anyone, that there are subtle issues of bias and interpretation and uncertainty in the encounter, which drives some of the different sorts of thinking. So Hector, where we are right now, we know that we can drill down and get relevant data to understand that disparities do exist. Not just differences, but true disparities. And we know that there are some community issues that can be addressed, some hospital issues, even provider issues. But now, Keith brought up the greatest segue in the world. He said it's all about the patient. Every last one of us believes that fervently. But the patients that seem to be most impacted are the women, the African American women and the Hispanic women. What is the depth of disparate care there, and what can we do about this?
Well, I think one of the things we didn't discuss too much is the issue about cultural competency. I think not only you're talking about the provider-patient issue, and then you add on that the cultural competency. For example, in the Hispanic population, the beliefs of the people, the belief to the African Americans is the same. I think one of the missing pieces to get these disparities, or at least to finish up with the disparities, is the lack of cultural competency. There is data, by the way, that the residents, the trainees don't understand these disparities or don't understand that there are disparities. So there are many places, like, for example, the Office of Minority Issues, Health, in the Department of Health and Human Services, that they have training in these issues. I think that's another missing piece. Obviously, I think there is one key, and there is some data, by the way, that if you have in the heart failure populations, in the Hispanic populations, women with this, that they have, if you teach them in Spanish, so the data is in Spanish, the adherence to medications, ACE inhibitors or beta blockers, is higher.
Yeah, they get it.
They get it. They get it because if not, we don't explain it as well as Keith mentioned the clopidogrel.
Well, one of the things that we have to caution against is that when we're talking about healthcare disparities, this is not a euphemism for black.
Exactly.
There are many different groups that are on the radar screen here. A function of gender, a function of ethnicity, a function of race, a function of lifestyle choices. And so we have to be very aware that women kind of have a double hit.
That's
They're
right.
part of a minority group and a gender group. Guys, we've had a great discussion today about some really deep issues that have to do with disparate care. But to close it out, I really want to come back to Hector and start with one question and hopefully get one crisp answer from everyone. We have a bunch of guys listening to this that are saying, I'm busy already, my billing is under assault, the quality folks are nipping at me every day, and now you want me to be sensitized to this disparity of care issue. Why should the cardiologist listening to this message care? Give me one crisp answer to that question. Why should they care?
Well, I think we doctors, we have to offer the best health care to every patient that we have. And therefore, that's the way we're going to reduce disparities. I think Keith mentioned that during his comments. That's the best way to go.
So it's all about the patient.
It's all about the patient.
Keith, what can you add to that?
First of all, I agree with Hector. It's a wonderful answer. But additionally, preventive care saves money. When you have African Americans with poor control of blood pressure, poor control of diabetes, we pay for it because those patients are entered into Medicare for dialysis, $40,000, $50,000, $60,000 a year. Readmissions for heart failure, readmissions for angioplasty. We pay for that. So if we don't do it for the right thing, let's do it to save money. Preventive care saves dollars.
So there may be some unrealized gains by making care more equitable and reducing unnecessary expenses, and we should all tap into that.
That's correct.
Tracy, what is your answer to that one question? Why should the doctor listening to this care?
Well, what better time do we have to do this, to achieve this? We've now got great data that can help us with our observations and help us influence our strategies. We've got great tools at our hands. We've got all these new technologies that can help physicians improve the quality of care that they're delivering. So this is the best time to be doing this, to be paying attention, and to be doing something about it.
I really want to thank all of you because this has been a really terrific discussion about an issue that could have taken us time over and over and over again to try to address, and we all brought it forward in very crisp, succinct, clear ways. For the listener, let me just tell you that what we've tried to do is to tell you that disparate care is real. It affects a large segment of the population. We as physicians have an obligation that we accept to provide the best care to patients in need at their greatest time of need, and we want to be certain we do that equitably. We've learned today that we can use registries to identify the problem and understand the difference between just a healthcare difference and a healthcare disparity, and we understand that there's some intriguing, effective strategies at the provider level, at the system level, and at the patient level that coming together can help narrow this gap. And we've been sensitized that some elements of our population are uniquely feeling the burden of disparate care, women especially, minority women especially. That's not who we are as physicians. We are committed, we are pledged to provide the best care to all persons in need. And what we're doing as a part of Credo is we're giving you the tools, providing you the incentive, making you aware that this is not because any of us aren't practicing good medicine, it's because all of us want to practice better medicine. Thank you for listening in. Stay tuned to more news and information from Credo. We really appreciate your attention to this issue.